Hello everyone, this is Kyle Peterson. I'm Managing Director at SSG, and we're thrilled to welcome you to today's webinar on Competing by Saving Lives, Stories of Implementation. We have a fantastic panel for you today. We have Karl Hoffman, President and CEO of Population Services International, Duncan Le Roux, Senior Vice President, Developing Countries and Market Access, GSK, Olav Nilsson, Program Director, Corporate Sustainability at Novo Nordisk, and Kathy Pekus, Vice President of Global Citizenship and Policy at Abbott. Each of the panelists is going to talk about his or her experiences in implementing shared value within the global health sector. We'll be live tweeting today using hashtag shared value and global health. We hope you'll join us. Next slide, please. First, I want to give a quick introduction about SSG. We're a global nonprofit that provides strategy consulting, evaluation, and research to clients around the world. We were started in 2000 by Professor Michael Porter at the Harvard Business School and Mark Kramer. And we now work across all sectors to help organizations to solve social problems. Increasingly, this means working with companies in the global health sector, nonprofits, and NGOs on shared value projects like the ones you'll hear about today. Next slide, please. We're looking forward to a great conversation with our panelists and with you, and so we'll leave some time for questions and answers. You can enter your questions at any time by typing your question into the box on the lower left-hand corner of your screen. You'll not be able to answer all questions, obviously, but we will try to get as many as possible, especially the questions that broadly reflect the themes that we're hearing. We are very excited to hear from you, so please do send those questions. Many of you are already familiar with the concept of shared value from the Harvard Business Review article and from our recent report, Competing by Saving Lives. For this webinar, we want to concentrate on the concept of shared value as practiced by pharmaceutical and medical device companies in the global health realm. I want to begin by briefly recapping the key ideas in the report. Next slide, please. As a start, it's important to say that pharmaceutical and medical device companies unquestionably create shared value, as they have contributed to great improvements in health and well-being. But this shared value has been concentrated in established markets of North America, Europe, and Japan. As you can see on this slide, pharmaceutical sales are dramatically out of whack with the burden of disease in the world. North America and Europe make up 3/4 of the pharmaceutical sales, but represent less than 1/3 of the percentage of deaths due to treatable illness. This picture is nearly identical for medical device companies. Next slide, please. By and large, companies have responded to this imbalance with corporate social responsibility and philanthropy programs. Starting with Merck's Mectizam program in the 1980s, we've seen amazing innovation in product donation, capacity building, and R&D partnerships. It's important to note that these programs serve very important patient groups in remote places of the planet, and millions of lives have been saved. But as many companies have learned, the resources available for CSR and philanthropy pale in comparison to the problem. Around the world, 1.7 billion people lack access to essential medicines, in many cases drugs that could save their lives. Next slide, please. For quite some time, companies have held the assumption that patients in low and middle income countries represent little or no commercial interest. But the basis for that assumption is changing for two reasons. First, margins are under pressure in high income countries. That's a different story for another day. Second, as you can see on this slide, low and middle income countries will be the fastest growing markets for pharmaceutical and medical devices over the next several years. Next slide, please. As you'll hear today, and as you can read in the report, these startling projections could become even more significant through concerted shared value approaches. Companies such as the ones featured in this webinar today are systematically and relentlessly uncovering new unmet health needs, finding new and better ways to address them at scale. Our report shares many examples of how companies are beginning to compete on the basis of improving health outcomes for the underserved through three mutually reinforcing levels. First, companies are developing new products, adapting existing ones, or tailoring their offerings to meet local conditions. GE's Mac line of electrocardiogram systems, which are battery-powered and sold at a fraction of their cost in European and U.S. markets, is a great example of reconceiving products and markets. Second, companies are changing the way they manage their value chains through more localized R&D, more efficient manufacturing, and innovative distribution. Lastly, companies are beginning to roll up their sleeves and strengthening the enabling environment in which they operate through investments in health systems. For example, Novartis's Aroiga Parivar program has built the capacity of partners throughout India, such that the company is serving 42 million people in 30,000 villages across 10 Indian states today. Next slide, please. And so we get to implementation, the focus of this webinar. So how are companies and partners getting the job done? Our research uncovered 5 common success factors among companies as they implement shared value. First, companies that excel at shared value have CEOs and country-level managers who bring a compelling vision and personal involvement to expansion efforts in low and middle-income markets. I'm sure that Duncan Le Roux will tell us about the important role GSK's CEO has played in championing shared value at that company. Second, among companies that are pushing shared value boundaries, we've noted a culture of innovation and learning reflected in structures and incentives. For example, companies like Medtronic and Novartis have specialized global health innovation units that coordinate shared value efforts across their companies. The third implementation principle is perhaps the most elusive. Among a few companies, notably Novo Nordisk and GE, we see new approaches to measurement that track the link between business value and improved patient lives. Such metrics offer companies a way to understand what works to create shared value and allows them to assess the potential of new investments, to allocate resources, and to set relevant incentives. Fourth, we heard about a diversity of new skills in identifying and acting on unmet health needs. At Becton Dickinson, for example, the company's senior leadership redefined the country's director's role, emphasized knowledge of local health needs, and strategic planning based on addressing those gaps. Lastly, new partnerships are forming for shared value insights and implementation. Pharmaceutical and medical device companies have long partnered with NGOs, donors, and global bodies such as WHO and Gavi. But companies are looking to a new set of partners to help with shared value strategy setting and specific competencies in adapting products, improving productivity and cost effectiveness, and strengthening the competitive context. Many of these partners are nonprofits, which marks a shift from prior roles as corporate philanthropic grantees. We'll hear about these 5 implementation principles during our discussion today. This is a great segue, as our panelists will share stories about shared value implementation. Let's first turn to Duncan Le Roux from GSK. Next slide, please.
Hello, everybody. Thanks, Kyle, and good morning, good afternoon, wherever you are listening in. At GSK, over the last few years, we've taken a much more ambitious approach to access to medicines. And as Kyle said, I think under a new CEO, Andrew Wissey, that's been a big factor towards that approach. In August 2010, we decided to form a new unit, the Developing Countries and Market Access Unit, which I lead, which focuses on the needs of least developed countries. The reason we did that is for reasons of the situation in those countries, as you can see on the left-hand side of the slide. The urgent challenge that exists with around about 800 million people in 50 countries, 40 countries in Africa and 10 in Asia. And those people obviously represent some of the poorest people in the world, and 50% of that population group lives on less than $1 a day. Another important dynamic that exists here is the lack of capacity in these countries to address the healthcare challenge. And if we take Africa as an example, the continent has to cope with 24% of the world's disease burden, with only 3% of the world's global healthcare workers and only 1% of global healthcare budget. So what we felt at GSK is that the special circumstances around least developed countries really demand a different solution. And what we were looking to do is to combine that access challenge with a business engine. So how can we actually link those two things together to create a sustainable approach that results in shared value both for our business and for patients? And the business opportunity is clearly there and is clearly important. And you see on the slide on the third bullet under situation, often these countries are growing fast economically, some of the fastest growing economies in the world, albeit from a very low base. And where we see that happening, we tend to see healthcare spending rising at a faster rate than economic growth. But actually there is an opportunity in the healthcare space. We also felt that we plan for success. So least developed countries won't all be least developed countries forever. And actually now is a good time to invest, to build footprint, build market share. And we feel that early movers like GSK, we hope, are able to build that footprint and build that brand recognition advantage. So we decided to form a new unit to tackle this challenge and opportunity. And the new unit is 50% focused on access and corporate responsibility and 50% focused on building our business for the longer term. Those two goals come together, if you like, through the strategy to support volume. So building our footprint for the future and building the volume of medicines we supply, which improves access to patients over the long term. And our goal is to increase the volume of medicines that we supply in these countries from around about 60 million units of medicine last year in 2011, and to increase that fivefold over the next 5 years. If you move to the next slide, you can see that what we are pursuing and how we are meeting that goal demands actually a new way of doing business. And the unit itself sits obviously within GSK and sits within our business, reporting into our emerging markets business. But it has essentially what I call new rules, new ways of doing business. So on the left-hand side of the slide, you can see we have rules around affordable products. We have capped our pricing for our patented medicines and vaccines to no higher than 25% of the UK price. We're also focused, and Karl referred to this in his introduction, to making our products more appropriate for least developed countries, where you have acquisition cost of medicines is critical, and you have patients who are usually on daily incomes, and therefore you have to get the price point right down to that level. And we have lots of examples of products that we're developing which get into those smaller pack sizes and lower acquisition costs for patients. Secondly, we have realigned incentives in the unit. So our employees are focused around volume and that's our incentive structure, is all about volume. It's not about revenue. And we also have a longer-term investment horizon. So rather than what you might see as a standard return on investment of 1 to 2 years, we are happy with a longer-term investment horizon of 4 to 5 years, providing that builds footprint and capacity for the future. Thirdly, infrastructure investment. We recognize the huge capacity challenges in least developed countries, and that's why we've committed to reinvesting 20% of any of the profit we make in each country that we operate back into healthcare infrastructure in that country, and we have some significant programs in partnership with NGOs around training healthcare workers across all the markets where we operate. Finally, there's a summary in that slide of the new structure, and just repeating that the dual focus here, which is corporate responsibility, but linking it with long-term growth from the business. And you can see there also on the slide, we have about 640 employees in the unit, so it's not a huge business in GSK terms, but it is significant, and we have employees in nearly every country of the 50 that we operate in. And to orientate you in terms of the size of the business, it's about a $200 million business at the moment. You go to the next slide. I wanted to give you just a quick overview of our strategy. So how are we actually going to make that 5-fold increase in volumes? We're actually going to focus, or are focusing, on 4 areas. Firstly, vaccines. We have an innovative vaccines portfolio which is particularly appropriate for a developing country setting. So our approach is to support our vaccines for diarrhea, pneumonia, cervical cancer, and we hope by 2015 a new vaccine for malaria. And we think that our vaccines portfolio will support probably half that 5-fold increase in volume that I talked about. Secondly, we want to expand our portfolio through registering many more medicines in least developed countries. At the moment, we have a portfolio that is really focused around infectious disease. And our goal is to expand that portfolio to include many more treatments for chronic disease, which will become much more of an issue in countries as patients live longer and as economic growth starts to have an impact. So we're looking at new medicines in terms of mental health, cancer, cardiovascular, and asthma. Thirdly, healthcare infrastructure. That talks to the 20% reinvestment I talked about, but also we aspire to taking more of a leadership position in healthcare infrastructure and acting more as a catalyst in terms of new models that can help to supplement and improve capacity in the countries where we operate. And that's good for access, but it's also good for our business. The better the healthcare infrastructure, the better capacity, the more medicines that we can supply. So we do see there's significant shared value in that support of healthcare infrastructure. Fourthly, it's about our people. So we need to be shifting our own unit and our own transition to people supporting our medicines, but ultimately leading to people who are acting in a much more engaged way with the healthcare challenges that exist in each of our countries, so that we want people to be able to approach dialogue with government, with NGOs, with the private sector. And rather than saying, well, these are the medicines we have, we want to say, you know, what are your healthcare challenges? Where are you trying to get to in the next 5 years? And how can GSK help? How can a company be a part of that and a partnership with you? So on that note, I will finish off and hand back to Karl.
Duncan, thank you so much. That was fantastic, and I'm sure we'll have some questions coming in for you. Next, we'd like to hear from Olav Nilsson, who is the Program Director of Corporate Sustainability for Novo Nordisk. Olav, over to you.
Thank you very much. Next slide, please. I'm very happy that you have the interest in calling in and listening to this shared value seminar. I'm going to talk to you about how we have sort of set up our business in China and why. I think most of you would know that China is one of the fastest growing economies, and with that comes unfortunately also problems such as diabetes. We will be right now, and we are looking at a number of some 92 million diabetics in China, and that we are foreseeing that number will be growing due to aging population, but also due to urbanization and other factors such as demographics, lifestyle, and these are factors we see all over the world, and that what we see is this non-communicable challenge disease is hugely important for healthcare system, because they will have large gaps that cannot be at the moment be dealt with. What we see is that there are some 70% of diabetics in China that are still not diagnosed, and 1 out of 10 of these diagnosed people are actually managing their condition to basically achieving targets. So this means that we are facing some huge problems for people with diabetes in China. We see low levels of physician awareness, and training of patients is a huge challenge. What we do see is, for instance, that a patient would have a minute with their physicians when diagnosed and when discussing diabetes, and this is when knowing how to deal with diabetes is a life condition that you really need to manage, and therefore new ways needs to happen, new things needs to happen. And what we are trying to do is go out and measure how can we do a difference for the barriers. And if you go to the next slide, then our approach is to, instead of competing for these very few people that are currently being treated and diagnosed, we think this is really not helping the situation in China. This is zero-sum thinking. We think, how can we instead grow the market? Can we somehow expand the access to the underserviced 97% of the people with diabetes, or people that are not at least being diagnosed or treated, and this is basically a focus we've had. We went into China some in 1994 and have had a huge success in China. But we did that basically with a shared value thinking. But at that time, we didn't know that there was that it should be called shared value. I think at that time we went into China and said, how can we actually make a strategy that will be mutually enforcing the Chinese society and our society? And one of the first things we did was to make a huge partnership with the Ministry of Health to develop national guidelines, because there was basically very little awareness of the problem in China. So if you go to the next slide, then we can basically went in and said, okay, if we're going to work well with the society, how is it that we can work on the different levels that really needs to be dealt with in a country where diabetes is developing to these catastrophic levels? And first of all, what we do, we work on how can we actually work on prevention, and this is, for instance, through the public-private partnership with the Ministry of Health. We have said, okay, how can we work with early diagnosis? And what we do, we have, for instance, a changing diabetes bus, which drives around in the country and are putting putting sort of actions down to the insufficient screening, and also making public awareness about the diabetes as a problem. Last, and to improve the quality of care, because we are really seeing that the insufficient diabetes treatment or ability to pay for treatment is a problem, because patients may not have this access to patients or to physicians, and therefore we are working very much with healthcare physician strengthening, and we have, for instance, trained some 50,000 physicians in how to deal with diabetes. The next steps that we are looking at is how can we segment the population to find sort of the greater opportunities. Right now, if you look at it, all pharmaceutical companies have been focusing on what will be the largest cities in China. And this is actually getting quite well covered. But when you look at that population, it's actually only capturing some 230 million people, and that still leaves 1 billion people with low or lesser access to healthcare services. And that's one of the challenges. And to sort of also learn more about how are we then. How are the things that we do? We actually do training of physicians in these areas. We've also gone out and said, okay, how is that perceived by the physicians in China? And we've sort of asked them, and when they come back and tell us, then we were surprised to hear that physicians in rural areas or in tier 2 cities, they were they got better results of our training than the physicians in tier 1 cities. And basically what we sort of concluded based on that was that the physicians in tier 2 cities or tier 3 cities, they were not seeing so many different pharma reps. And in this context, I think it's important to emphasize that a lot of the education that is given and that these physicians will get is actually coming from the pharmaceutical industry, because there's very little training, very little sort of healthcare education, re-education built into the Chinese system, especially on diabetes as a disease. So to conclude, what we are hoping to do, and what we are actually doing right now in a program called the Blueprint for Change program, we are tracking our progress and adjusting and optimizing the programs that we are running in, not only in China but in a lot of countries to optimize the program for best results. So over to you, Kyle, again. Thanks.
Thank you so much. Now we'll hear from Kathy Pekus, who's the Vice President of Global Citizenship and Policy at Abbott. Kathy, over to you.
Kyle, thank you very much for that introduction, and thanks to the entire FSG team for organizing us today. You know, as I was preparing for today's discussion, I looked back at a recent Harvard Business Review interview with Professor Michael Porter on the topic of creating shared value. And while he said many things worth repeating today, in the interest of time, I'll focus on just one thing in particular. You know, Professor Porter said that historically it was considered that what was good for business was good for society. And today, actually, the opposite is true, that what is good for society is good for business. And we at Abbott see the value in that statement as we enter markets like India, where there is both, you know, just a tremendous business opportunity, but at the same time, you know, complex societal issues that have to be addressed in order for business to be successful and for us to ensure that we're delivering, you know, exactly what's needed to the patients of that country. Now, digging in a little bit deeper for some context on India, here's a bit of background. You know, India, as stated on this slide, has many challenges, as most of you know. People lack access to affordable essential medicines. There's a robust gray market for counterfeit medicines. And the country lacks both, you know, infrastructure and the necessary level of public spending in the area of healthcare. And there's a tremendous, you know, disease burden. So as Abbott set out to do business in India, we were mindful of these challenges but eager to leverage some strengths as well. First, we had unique resources within the company and strong partnerships externally. Now, first on the internal part, Abbott has been operating at a respectable level of investment in India for decades. But it was 2 years ago when Abbott acquired Piramal, a local Indian pharmaceutical company, which then made Abbott one of the largest pharma companies in India. Everything changed. Now, expectations, our ability to deliver a wide variety of medicines, stakeholder engagement, wide variety of things. But much to my delight, and as we learned more about Piramal, what we found is that Piramal had created a social business unit called TrueCare. Now, the goal of this business was to provide medicines, branded generics, to a segment of society that to date had not been able to access medicines that it needed. Its motto is, simply put, to democratize primary health care delivery in India. Now, Piramal's strength was in the model that recruited, trained, and educated local citizens from these aspects of the market that we hadn't been able to reach, and provided them not just with access to inexpensive medicines, but also robust healthcare information. And thinking also about the business model from the head of this business unit, they're selling small quantities, sometimes 1 or 2 pills at a time, equal to about 2 cents in terms of what was being made as in terms of revenue in these communities. So significant challenges on that front. But it was a very interesting model and something that we could leverage as we were starting to think holistically about Abbott's presence in India. Next slide. Now, going on, the second strength that I just mentioned was our partnerships. This brings us to those strong external partnerships that we had, and one in particular was with the leading NGO, CARE, led by Helene Gayle. And I might add that while the business model is changing for all of us, the business models for NGOs are changing dramatically as well. And I have to salute Helene Gayle and her vision. Recently she announced the creation of CARE Enterprises. So here's a traditional NGO that has been operating in a traditional way, accepting grants from organizations, individuals, foundations, taking those financial resources, and then putting forth a strategy. What she has done here has really indicated that there is a strong shift in terms of NGOs and how they operate, in terms of what their expectations are and what their strategies are for their beneficiaries. No longer do they want to have their beneficiaries sit on the sidelines of the global economy. Moreover, they want to give them the tools and the partnerships to help them engage as active members in that global economy for the long-term success of these beneficiaries. So the work with Abbott and what we have embarked upon with CARE is really leveraging our lessons learned around Piramal and our trust and outcomes that we've achieved through our traditional partnerships with CARE. But what we're doing now is finding ways in India by which we can partner with CARE in terms of helping us do 2 things. Help us reach those aspects of society that haven't had access to medicines that they so uniquely and critically need. And secondly, we want to also ensure that the partnership is sustained for the long term, that we have a financial and business relationship with an NGO that will take both organizations well into the future to achieve these mutual goals. But I have to say, this is not an easy shift for either organization. And I think that as we embark upon these partnerships with NGOs in a business-like sense and creating shared value type model, it's important that we stay the course and be patient. It's going to take some time because I think both organizations have to address their processes, their skills, how they're organized to ensure that some significant changes are made so that there is more integration. Typically, partnerships are very kind of transactional. We've given grants to the organizations, they go off do their thing. Now we're business partners, and I think that the opportunity for success is there, but it's going to ensure that we take those necessary steps to create a business partnership where there previously was not one. But overall, we're excited about what will result for the long-term health infrastructure for the patients in India and elsewhere, and think it's a great model for us to keep you all informed on as we move forward. Kyle, back to you.
Kathy, thank you. That's a great bridge to our last panelist, who is Karl Hoffman, the President and CEO of PSI, and he's going to talk about new forms of partnership from the NGO perspective. Karl.
Thanks very much, Kyle, and hello to everybody on this webinar. Indeed, I was listening to Kathy's presentation and just sort of nodding my head as we at PSI, a nonprofit social marketing company, look at the shared valued partnerships and the challenges that they represent, but also the opportunities they represent. So I'm going to talk quickly about 3 examples that we've got. 2 of them are pharma, but one, as you'll see here on this first slide, is a fast-moving consumer goods company. So we're working with Unilever to promote water and sanitation projects in a number of different countries, and specifically in Kenya, Zimbabwe, and Vietnam to promote hand washing, using some of the brands, well, a particular brand of Unilever, but also focusing on the behavior and trying to get the behavior mainstreamed through school-focused programs. Also working on household water treatment solutions in other parts of the world with Unilever. What's the attraction for us? Well, Unilever is a world-leading, fast-moving consumer goods company that has a lot of experience with, I would say, middle of the pyramid and increasingly bottom of the pyramid marketing. We are a social marketing company with a social mission, not a profit motive, but using marketing tools to focus on that same segment. Increasingly, their business and our business aligns and overlaps. We think we can learn from each other. In this particular case, Unilever, the partnership with Unilever is helping us with our modeling. We use disability-adjusted life years as a way to measure our outcomes. That's our retained earnings metric, if you will. And every intervention that we have has a DALY associated with it so that we can track our cost effectiveness. Well, by partnering with Unilever on hand washing, we're able to develop the modeling necessary for a DALY eventually for hand washing interventions. And we know that these are going to be very cost-effective interventions to address that burden of disease that's underfunded and underaddressed in most of the 60-plus countries where we work around the world. Next slide, please. So I said there are 2 pharma examples I'm going to list. Novartis is one. We have a big relationship with Novartis in terms of anti-malarial artemisinin and combined therapy. That's the frontline medication used for treatment of malaria around the world. In Malawi, Novartis was looking to expand their reach into the market because there were a number of distribution challenges and problems with the public sector, number of stockouts, and the premium private sector with whom Novartis was traditionally working had a very limited reach. We, on the other hand, have a lot of experience in Malawi and elsewhere with what would be termed the non-premium private sector. So a part of the market that is with a lower price point, typically aimed at consumers lower down on the socioeconomic chain. But still, the private sector, typically in Malawi, as in many parts of the developing world, is reaching many more of these people, or is the only access that many of these people have to healthcare products and services because the public sector is weak. So here in this example, we have an agreement with Novartis for preferential pricing and using some branding that we are developing jointly with them to distribute on a cost recovery basis artemisinin combined therapy through the non-premium private sector. We're early on in this partnership. Malawi's gone through a difficult political transition recently and a big devaluation. These are big disruptive efforts or actions within our market. But nonetheless, we've seen uptake of this go much faster than we predicted. So the prospects seem good. We wanted to generalize this to other countries as well. We have a lot of malaria treatment and control programs around the world. But we ran into some roadblocks, and I think Kathy was alluding to that as some of the challenges as nonprofits and for-profits explore this shared value space. We could probably have a whole other webinar on those challenges, but just to put that on the table, there are difficulties as we try and find win-win solutions for both. Next slide, please. Finally, Merck, as another example, Merck has a Merck for Mothers commitment that probably many of you know about. It's a very substantial $500 million commitment that Merck has made, working with a number of partners and governments in the developing world for safe motherhood. In Uganda, we're delighted to be working with Merck to expand our social franchising work in Uganda, again using private sector providers to reach women and mothers with healthcare products and services. But specifically in this partnership, Merck has lent us a number of their, what I would call ninja marketers. These are marketing professionals from within Merck who are detailed to PSI to help us with the execution of our marketing strategies and to improve our ability to deliver value to the consumers, the $1 and $2 a day consumers who are our target audience. So we have them for a number of months. They're helping us with our strategies in Uganda, also in Myanmar, elsewhere around the world where we have social franchising programs. They learn about our distribution and marketing systems. We learn about top-line marketing execution skills from one of the leading pharmaceuticals. Final slide for me. Next, please. So just to go back to the principles that the important FSG paper identified as success factors in shared value, you know, in the examples that I've talked about, we have, particularly with Merck, focused and determined leadership at the corporate CEO level as well as at the country levels for us. With Novartis and Merck, we have a desire for mutual learning and shared innovation in terms of modeling, in terms of new channels of distribution. With Unilever, we see examples of new approaches to measurement. I mentioned the help that we're going to get from them to develop our DALI modeling even more extensively. And these partnerships just in general for us are a way to really explore new and creative ways to deliver value to our consumers and ultimately to our funders, our public funders, who are using social marketing and what we can provide as the tools of social marketing to reach poor and vulnerable consumers. So from our perspective, the shared value space is exciting. We learn a lot from it. And we look forward to more partnerships as we try and grow our impact around the world. Thanks, Kyle.
Karl, thank you so much. So I've been monitoring the questions that you all have been sending. We've received about 30 questions, so we're going to have to pluck among all these gems that we've found here. And since we've been talking about partnerships over the last 15 minutes or so, why don't I direct this first question to Ole, Duncan, and Kathy, okay? And this is about partnerships. How has shared value thinking changed how you approach discussion and partnership with global health stakeholders? Why don't we hear from Ole first, Kathy, and then Duncan?
Okay, let me be brief. I think for us, it's I would say one word. It's transparency. Definitely when we go out and talk to our partners and global health stakeholders, then when we come and talk shared value with them, they're feeling, okay, you're putting everything on the table here. Before, when we were talking CSR, or what we denote as the triple bottom line, never really indicating what was our upside of this relationship, then people were always looking for that upside, thinking there were some other agendas, or what is really their agenda, or they're just into sales. And yes, we are a company. We are earning money on selling drugs. And this is a fair deal, and what the shared value is giving us is a real tangible way of talking about the fact that we are, as a company, trying to, of course, do something very good for society, but at the same time optimize our own sales and value creation. And I think for us, this has been definitely the strongest part. And then on the path to that and measuring the shared value, it is also giving us some guidance on how can we maximize shared value, what are the activities that are providing better value for society and for us, and how can we integrate that into our leadership decisions going forward as well. So that's a more internal focus as well. But for the shareholder, back to the global health stakeholders, that's really transparency is really the one of the key outcomes.
Great, Kathy.
Yeah, and I'll tell you, I have to say that the conversations on shared value with stakeholders have been very positive. The reaction has been very positive because I think what the expectations are greater than what they've received with regard to some of the traditional philanthropic programs. I think that what they see now is that we're getting to the key issue of access in a more long-term, sustainable way. And I think we're getting great positive feedback from that.
And Duncan.
Yeah, I'd really agree with Ole on the openness and transparency. I think certainly from the company side, being very clear what we're getting from it, what we're going to charge, what profit we're going to make, being very open about that. And I think that's not the history of the industry. So I think just sort of signifying a bit of a change there, I think is important. And secondly, being more open and probably a little bit braver about what we're expecting from the partner. So in terms of incentives, energy and motivation, and what kind of system is going to drive that, and being clearer about that. Secondly, I think trying to bring faster decision-making, clearer accountability to things. And I think, it's hard enough to get things done in developing countries, as we all know. And, what we've got to try and do is, at the company NGO level, be quick as we can and just get on with stuff. And then thirdly, I think it's actually choosing the right partner that responds in the right way to those things, so that is also open and transparent, that kind of gets it from the company's perspective as well as from the patient access perspective, and also the NGO that is got clear accountability and that is, can do quick decision making.
Great. Duncan, thank you. So Karl, following this theme of partnerships, we have a few people who have kind of picked up on this theme from Kathy about how NGOs are also changing their business model, which is pretty provocative. So in your mind, should NGOs be more proactive in sort of naming their offerings and positioning themselves to companies? It seems right now that a lot of the effort by NGOs in reaching out to companies maybe is not so clear on shared value.
That's a good question. I think as both Kathy and you have put it, there's a traditional model of interaction between corporations and NGOs, and it's been a lot focused around CSR and, as Kathy said, transactional relationships. All I can say is we see that as the past, not the future. I can't speak for everybody in the NGO sector, but these corporations and NGOs in different ways are engines of value creation. And the sooner we can figure out how to really align business practices so that, I would much prefer to be dealing with a corporation in a P&L sense than in a CSR sense. I think we need to move the relationship between corporations and NGOs increasingly out of the CSR context and into the P&L context, because that's really how you build sustainability. It's not always going to work. There are competing and conflicting objectives and motives, but there's more alignment than we often assume, I think, and we should explore that actively.
Thanks, Karl. So moving from, I guess, this notion of stakeholders to shareholders, we had a couple questions come through about investors. So for Duncan, let's start with Duncan, and then move to Kathy, and then Ole. Here's a question, which may be a little tough, which is, what have been the reactions from investors regarding shared value and your effort behind it?
So I think it's a very good question. I think probably the first answer to the question is that this approach is unlikely to be material to the company. So it's unlikely to influence an investor decision, whether to buy or sell or invest or whatever in a company's shares. Having said all that, investors are very interested in how companies are evolving and are obviously looking at the strategy from that perspective. In my experience, I've presented the GSK model to investors, and they kind of fall into two camps. One camp sees it as incremental business that the company wouldn't necessarily get anyway, and therefore, as long as it's profitable, then that's good to have, right? So that's good as an investor. They also recognize the importance of making a difference on access and the CR element to what we're doing, the whole kind of license to operate, and that, in a sense, is investing for the future in terms of your position in society, in the world. The other camp of investors, frankly, are worried about dilution. They're worried about the margin. So in my unit, for example, we operate about a 20% profit margin, which is similar to an Indian generic company, for example. Whereas within emerging markets, we're more like 35%. So they kind of think, well, I'm just worried about the dilution. I think for me, of course, investors are always going to have different views. I think what's important is, this is what we're doing, this is our strategy, we believe in it, and investors therefore have to take a view either way, whether it's something that they like or that they don't like.
And to just build on what Duncan has said, it's Kathy and I agree. I think one of the things that investors are keeping a sharp eye on is the business strategy in emerging markets. They understand that they're complex marketplaces with all kinds of challenges, and I think they're looking to business to see how they sustain their operations and don't try to force fit a model that has been successful in the West into these markets. And these innovations, I think, will pay off over the long term. Again, back to the challenge in terms of the profitability. Again, when you're selling products at lower margins and you're pushing on the volume, that's going to be your key to success.
And I think what I can say for what the investors have been sort of saying, but then we know very directly because we've created these shared value cases, a blueprint on China and one on US and now one on Bangladesh. And they have actually been presented 2 years in a row for our investors. I would very much agree that you can divide the investors into two categories. There would be the investors that would normally look at profit and loss and what is actually in our development lines and all that, and how does our R&D look like, and what's the probability of success. And those factors are still the most important parts on companies such as Novo Nordisk, at least. When it comes to sort of building for the future, I think that's where investors are interested. When they hear that some 50% of people with diabetes are coming from developing countries, then they would say, okay, it's likely that it's interesting what you do, and therefore we will monitor very closely these results that you come up with, and this is also giving us a broader understanding on how you are creating value and are preparing for the future. So that would be the other segment of investors as well. I would say that would be having this more broader value view.
Great. Thank you, Ole. We've got time for just one last question. We have one. This is for all the panelists. And if we could just keep it to maybe 2 or 3 sentences because we are limited to time. Question came through that asks, for young professionals who are very intrigued with this shared value idea, what type of backgrounds and competencies are you looking for to hire? Why don't we start with Karl?
You know, we draw from all sorts of different backgrounds. We work in development and we're a nonprofit, so as you would expect, we get a lot of people who come with a background, for example, in the Peace Corps. But some of the most successful people in my enterprise are those who have private sector backgrounds, marketers, Coca-Cola, General Foods, General Mills, and we have a sort of an expectation of people going back and forth from our world into the for-profit world. For example, we're losing a key employee to Merck in the near future. So business backgrounds for us are really crucial to achieving our social marketing mission, and anybody who's interested in this intersection of profitability and social responsibility, I hope you'll look us up.
Great. Duncan, Ole, and Kathy, and if you could please just keep it brief.
So I look for generalists. We're pretty light on infrastructure in our unit, so people have got to be able to do different things. They've also got to be good at looking for opportunities, a little bit entrepreneurial. Secondly, forming connections and engagement and building relationships. Thirdly, a medical background, very helpful. You know, it helps to build credibility. You've got to really understand from the patient's perspective. And fourthly, you've got to care. You've got to care about access. You know, you can't just be, you know, focused on business. You've got to have a mindset that cares about patients, that cares about access. Thanks.
Ole?
I would say very much like Duncan, we are looking at people that really care. That's people with a passion, and then of course they need to have some sort of background that can combine having a foot in each camp. So you need to have some at least business acumen, and you need to have some social acumen as well, and you need to be able to combine and understand and talk the language of both sectors. But when that is said, I would say passion is really the overriding factor when we hire.
Kathy.
Very quickly, policy background, has spent some time with an NGO, go get your MBA, live in India or China for a while, develop some language skills, and don't be afraid to take risks.
That's terrific. What a great way to end it. Listen, everyone, thank you so much for attending. I'd like to thank our wonderful panelists, great contributions today. We would also like to thank our partner, GBC Health, who helped to make this webinar possible. Just to let you know that a recording of this webinar along with the slides that we used today will be available in the next day or so on our website, fsg.org. And please help us improve the quality of our webinars by filling out a brief survey that will pop up at the end of the webinar, which will end in about 10 seconds. So thank you all very much, and please keep your eyes on FSG. We'll be having other webinars in the future. Take care.